Welcome back to The Explainer. Today we're diving into dopamine, a drug that honestly has a bit of a split personality. It really depends on where in the body you're looking. So let me ask you, when you hear the word dopamine, what's the first thing that pops into your head? Is it that feel-good chemical in your brain, the one linked to reward and motivation? Or is it a critical, life-saving drip we use in the ICU? The thing is, they're both right. Right, so in the world of neurology, dopamine is an absolute A-lister. It's a key player in how we move, how we feel, our motivations, the whole shebang. And just like this slide points out, when those dopamine-producing neurons are lost, that's the devastating hallmark of Parkinson's disease. But, okay, let's leave the brain for a second and walk into an ICU. Here, dopamine is a whole different animal. We're not talking about a subtle neurotransmitter anymore. We're talking about a powerful drug, a catecholamine, that we push through an IV to literally save someone's life when they're in shock. So, how can one little molecule wear two such different hats? Well, that's what we're going to unpack. We'll look at its two faces, see how it actually works, talk about when we use it and the dangers involved, what it means at the bedside, and we're going to wrap up by busting a huge clinical myth. Okay, first things first. To really get dopamine, you have to understand the science behind it. And it all boils down to one single crucial concept. What it does completely changes depending on how much you give. Let's get our terms right. Pharmacologically, it's what we call an agonist. That just means it turns on certain receptors. Specifically, it hits adrenergic receptors, think your fight or flight, alpha and beta, and also dopaminergic ones. So, what does that mean for our patient? Therapeutically, we use it as an ionotrope to help the heart squeeze harder and a vasopressor to squeeze the blood vessels and get that blood pressure up. Okay, so this is where it gets really interesting. At a low dose, dopamine mostly just, well, it tickles the beta-1 receptors on the heart. The result? A stronger pump, which means better cardiac output. It can even relax the blood vessels a bit, making the heart's job easier. Now, what happens when we start turning up that infusion? In that middle range, the alpha-1 receptors start to wake up. We're still getting that great heart support from the beta-1s, but now we're adding a little squeeze, a mild vasopressor effect that starts to bring up the blood pressure. And then, when we really crank it up to high doses, forget about the heart effects. It's all alpha-1 all the time. At this point, dopamine is pretty much a pure vasopressor. The main event is squeezing those vessels hard. It's like it's become a completely different medication. This table is just a perfect summary of that personality change we were talking about. Just look at that alpha-1 line. It goes from nothing, 0 at a low dose, to a massive triple plus effect at high doses. This shows you exactly why dialing in the right dopamine dose is such a critical skill. So, how does dopamine behave once it's in the body? Well, it's a very short and very intense trip. It kicks in within minutes, but check out that half-life. Only about 2 minutes. That's why it has to be a continuous infusion. The moment you turn off the pump, its effects are gone. The body just chews it up super fast. All right, we've got the science locked in. So let's bring this into the real world, to the bedside. This is where we have to weigh the benefits against some pretty serious risks. So when do we actually pull dopamine out of the toolbox? Its main gig is treating shock. We're talking about a patient whose blood pressure is in the tank, even after we've loaded them up with fluids. It's a key player in cardiogenic shock, when the heart's just not pumping right. Now, in septic shock, you can use it, but honestly, it's usually the backup player to norepinephrine, mostly because it has a higher risk of causing heart rhythm problems. Yeah, this drug is powerful, but it's not without its dangers. Since it's basically flooring the accelerator on the heart, the biggest risks are cardiovascular. We're talking about tachycardia, dangerous arrhythmias, even chest pain. And there's one complication that every clinician dreads: extravasation. If that IV leaks, this drug can literally destroy the tissue around it. I love how this slide lays it out. There are use with caution situations, and then there are absolutely do not use situations. Like, you would never give dopamine to someone in VFib. That's a hard stop. But for a pregnant patient or someone on certain antidepressants, it's not a definite no, but you are going to be incredibly careful. Okay, so this all leads to the big question. What does this mean for you at the bedside when you're the one hanging the strip? There are 4 things that are absolutely non-negotiable. 1, your eyes are glued to that cardiac monitor. Blood pressure, heart rate, EKG, everything. 2, You are watching that urine output like a hawk. 3. You're constantly checking that IV site and making sure their hands and feet are staying warm and pink. And 4, you're titrating, making tiny, careful adjustments to that infusion rate to get just the effect you want and nothing more. Okay, so how do you explain this to a patient or their terrified family? You keep it simple and direct. You tell them this is a very strong medicine to help your blood pressure. You reassure them, we are going to be watching you and your heart monitor every single second. And you empower them. Please tell me the instant you feel any chest pain, if your heart feels like it's racing, or if there's any pain at all where your IV is. Okay, time for a clinical pearl. This is a big one. It's a classic test question for sure. But more than that, it's an old piece of medical dogma that, believe it or not, you might still see out there. Let's bust the renal dose myth. For years, decades, this was a thing. The idea was, hey, what if we run a tiny dose of dopamine, a so-called renal dose? Can we use it to protect the kidneys when they're taking a hit? And on paper, it made so much sense. We know for a fact that low-dose dopamine increases blood flow to the kidneys. And more blood flow has to be good, right? It should protect them from injury. The logic was sound. But then we actually studied it properly. And the data from this huge meta-analysis in 2005 was a total game changer. It showed zero benefit. It didn't save lives, it didn't stop people from needing dialysis, and it didn't even reduce side effects. So here's the bottom line, the take-home message. Using dopamine just to protect the kidneys is old medicine. It's an outdated practice with no evidence to back it up. Yes, it might make the patient pee more, but that doesn't mean their kidneys are actually doing better. It should not be used for this purpose, period. And really, this is such a great lesson for all of us, to always question why we do what we do, and to follow the evidence, which kind of leaves you with one last question to chew on, doesn't it? What other things that we do every day at the bedside, just because it's how it's always been done, might be due for a serious rethink?